So you see J-point elevation on an ECG in a young, healthy patient. For decades, the textbook answer was simple. Call it a normal variant and just move on. But as we're about to find out, that is not the whole story. What we once thought was a totally benign finding, well, it turns out it has a much more complex and sometimes a much more dangerous side. All right, so here's our roadmap. We're going to start with that classic view of early repolarization. You know, the one we all learned. Then we'll dive into its surprising and pretty scary link to sudden cardiac death. After that, we'll hammer home the critical difference between the pattern and the syndrome. Learn how to spot the high-risk features on an ECG, and finally, wrap it all up with management and the key things you need to remember.
Okay, let's start with what most of us were probably taught in training. For the longest time, early repolarization was seen as, just an electrical curiosity, nothing to really worry about.
So picture this. An ECG from a pre-participation physical for a young athlete lands on your desk. You see this pattern. What's the first thing that pops in your head? For most of us, the gut reaction is, oh, that's just early repol. It's a normal variant. And for a very long time, you would have been 100% right. And this is exactly why. The textbook definition describes it as J-point elevation, at least 0.1 millivolts, in two adjacent leads. And it often has this characteristic slurred or notched look, right where the QRS complex finishes. And because we see it all the time in athletes and healthy young people, it wasn't just considered benign. It was almost seen as a marker of a healthy heart. But this is where the story takes a pretty dramatic turn. New evidence has forced a huge shift in how we think about this pattern, and it all starts with a surprising and, frankly, dangerous connection. It turns out, modern studies, especially the ones looking at survivors of sudden cardiac arrest, have connected this once benign pattern to a real increased risk for arrhythmic death and for idiopathic ventricular fibrillation, or VF. And VF is that life-threatening arrhythmia that happens without any known cause. I mean, this discovery completely changes the game. So you have to wonder, why did we miss this link for so long? The answer is just prevalence, sheer numbers. This pattern shows up in anywhere from 5 to 13% of the general population. That is a huge number of people. It's so common that for decades, its connection to a really rare event, like sudden death, was just statistically invisible.
But now, the data's pretty clear. When you look at the meta-analyses, people with the ER pattern have a relative risk of 1.70 for arrhythmic death. So even though it's a common finding, it does carry a real, quantifiable increase in risk.
And this leads us to a really crucial paradox. How can something so common also be a risk factor? Well, it all comes down to absolute versus relative risk. Because the pattern is everywhere and sudden cardiac death is thankfully rare, the absolute risk for any single person who just happens to have this on an ECG is still incredibly low. This is why we don't screen the entire population for it. Context is everything. And that idea of context brings us to probably the single most important clinical concept in this entire topic, understanding the huge difference between the early repolarization pattern and the early repolarization syndrome. They are not the same thing. So here's the difference in a nutshell. The ER pattern is that super common ECG finding we see in a person with absolutely no symptoms. The management? Simple. Observation. On the flip side, the ER syndrome is incredibly rare. It's the exact same ECG finding, but this time it's in a patient who has survived a sudden cardiac arrest from ventricular fibrillation. And the management there couldn't be more different. They need an implantable cardioverter defibrillator, an ICD. So, same ECG, but a completely different patient and a completely different prognosis. Okay, so if most people with the pattern are going to be just fine, how do we identify the few who might be at a higher risk? Well, this is where we have to put on our detective hats and learn to read the specific clues hidden right there in the ECG. A great place to start with risk stratification is location. This classification system is super helpful. Type 1, where the pattern is just in the lateral precordial leads. That's what you see in healthy athletes, and it's largely benign. But as the pattern moves to the inferior or inferolateral leads in type 2, the risk level bumps up to moderate. And a global pattern, type 3, that's associated with the highest risk. And beyond just location, we're looking for other warning signs. First, the amplitude. If that J-point elevation is greater than 0.2 millivolts in the inferior leads, that's linked to a threefold increased risk of cardiac death. Second, look at the shape of the ST segment right after it. A nice concave, upsloping ST segment is reassuring, but a horizontal or downsloping ST segment, that's a major red flag. You also want to pay attention to the J-wave itself. A sharp notch is thought to be higher risk than a gentle slur. And finally, keep an eye out for low amplitude T waves along with it. Okay, let's pull all of this together and talk about what it actually means for clinical practice. How do we take this knowledge from theory and apply it at the bedside? First things first, it is so important to remember that ER syndrome is a diagnosis of exclusion. You are only making this diagnosis after a patient has survived a cardiac arrest, and after a full workup has failed to find any other cause, like coronary artery disease or some other cardiomyopathy. And that workup has to be exhaustive. I mean, you're systematically ruling out every other possible reason for the arrest. This means comprehensive testing, things like cardiac monitoring, an echo, maybe a cardiac MRI to look for subtle structural problems, and a coronary evaluation to rule out ischemia. And only after all of that comes back negative do you go back and scrutinize every ECG you can find for those high-risk ER patterns we talked about, paying extra close attention to any tracings from around the time of the event. And in some cases, you might even consider genetic testing. So once the diagnosis of ER syndrome is confirmed, the treatment plan is pretty clear. The absolute cornerstone of therapy is an ICD for secondary prevention. If you're in the middle of a VF storm, IV isoproterenol can be a lifesaver. For patients who keep getting shocks from recurrent VF, quinidine is a good option for chronic suppression. And in the really tough refractory cases, catheter ablation can be considered. So let's just put the most important point out there one more time as clearly as possible. For the millions of people walking around with the asymptomatic ER pattern, the right approach is observation and reassurance. But for that very small, very specific group of patients diagnosed with a life-threatening ER syndrome, an ICD is mandatory. The patient's clinical status, that's the critical differentiator. And this leaves us with the biggest question, and really the next frontier in this field. We know the pattern is everywhere. We know what the high-risk markers look like after a catastrophe has happened. The real challenge now is figuring out how we can use all this knowledge to identify those few high-risk individuals before they ever have a cardiac arrest. That's the puzzle we still need to solve.